see here. Don't know where it comes from, but is a series of questions here. So if a child has no compression issues, are they out of the woods as an adult? If not, what signs to be aware of, and should achondroplasia have MRIs every so often? So I believe that this question refers to the foramen magnum, and the answer to this question is usually we think that as people get older, the likelihood that critical foramen magnum stenosis requiring decompression need be done goes down. We think the risks are highest during the first 2 years of life, and then they gradually go and fade out. Certainly we do have or have had older kids that have needed a decompression, but I would certainly think that once they have reached skeletal maturity, there is really no risk for foramen magnum stenosis that would require a decompression. Now, whether or not someone needs foramen magnum decompression is very independent of whether or not they may or may not need lumbar spinal decompression surgery for stenosis there, which is almost always a problem of adulthood rather than childhood. In terms of routine, quote-unquote, baseline MRIs, that is not something that we do routinely in our practice. We take images when we believe that problems may be present based on physical examination, history, or for other reasons. Do kids with achondroplasia have growth spurts like average height kids? In general, the answer to that question is no, they do not. If you look at the achondroplasia linear growth grids, you do not see a bump in the curve. So as a population, this does not seem to occur. Certainly there are individuals who may move slightly up on the curve during this period, but in general there's not a clear-cut growth spurt across the population. And we believe that this is because, as I discussed before, the hormones in the body, while they may be pushing the system, it's the growth plate's ability to respond that is impaired. And just because there's more growth hormone circulating doesn't mean that the growth plate is going to be able to respond any better. Do the bones of children with achondroplasia heal faster than average height bones? Does it make a difference between boys and girls? The problem with achondroplasia is really in the growth plate cartilage. At this point, there's no reason to suggest that there's any difference in the bone structure. I would not think that there's any difference in bone healing between typically developing kids and achondroplasia children, and certainly not between boys and girls. Do you know of any differences between people with G to A achon mutations and G to C achon mutations? Have any differences been noted? So this refers to the individual spelling mistake inside the FGFR3 gene. Achondroplasia is caused by changes where the G goes to A or the G goes to C at this one particular codon. Regardless of whether or not the change is to A or to C, it results in the same protein substitution. It creates the same missense mutation, so that we would not expect any differences to be present because the FGFR3 protein is the same in patients that have either G to A or G to C mutations. And the last of this series of questions says, is there any connection between hypochondroplasia, neonatal seizures, and learning disabilities? So this is a very complicated question. So one at a time is hypochondroplasia is not often recognized at birth. Oftentimes kids come to attention between 3 and 5 years of age. We do believe that there is a relationship between hypochondroplasia and various learning disabilities which can become recognized at school age. There's certainly a relationship between seizures in the neonatal period, which often result from low oxygen levels in and around birth, and subsequent learning disabilities. So there's a relationship between those two things that's independent of hypochondroplasia. We also do know that people with hypochondroplasia may have a very small risk of having a specific type of seizure, often originating from the temporal lobe or temporal lobe epilepsy, but usually this does not present in the neonatal period, but at a much greater age. So this is a very tricky question to answer, and not clear what the question is really trying to ask. But there's definitely relationships between these things, but perhaps not all related, all three of them together.